think I want to start with my journey. It's a long journey for theory and for a ride. But I think like many of you here, I went to medical school and I got my license. And I went to an undergraduate medical school in Australia, which is 5 years. So from 2015 to 2019, I attended that. And during medical school, I've had a lot of varying interests. So initially I wanted to be a neurosurgeon, and then I flipped back to maybe family medicine or general practice, consider other career paths and whatnot. But during the time, I think I've always had interest in public health and global health as well. So I did try to get exposure to this area. So I did some practicum in kind of like PG, and then did work as well, and where I went uh, with health and a little bit of internship there. So try to keep my interest broad and the exposure. But I think at the end of it, I wanted to do some clinical work and went through the normal pathway that we normally do. And in Australia, I'm not sure about where you're from. We do 2 years of generalized training. So we call it internship and residency before you kind of specialize into your specific pathway of your choice. 2020 was the first year I started work. And as you would recall, that's also the year that this very annoying virus started to circulate the world called COVID. And it really was a surprise. I had 1 month of COVID-free practice. And then after that, it was complete mayhem to some degree. And I started off in emergency medicine. And, in Australia, you go through monthly rotations of different specialty from internal medicine to surgical to emergency and whatnot. So it was quite a shock to the system. And I think my first year was quite challenging. Maybe I had a few kind of edges of burnout and things like that. And it really made me, I guess, reflect back a little bit about kind of what I wanted to do with my career, whether clinical medicine was kind of the thing I wanted to do, or whether I wanted to explore other pathways like public health, global health I was alluding to earlier. And in Australia, at least, it's quite common or not unusual for people to take a year off between finishing their general training after year two to like a specialty training. So I wanted to utilize that opportunity to, try something out within this field. So towards the end of my general training, I applied for a bunch of Master of Public Health programs and was fortunate enough to get into Johns Hopkins in America to do a 1-year course. So I wanted to take that opportunity to get as much exposure to what this is like and see if it's the right path. And initially, I was more interested in maybe some research careers, and I think I was interested in like health security, biosecurity element. I guess partly affected by COVID and the impact it had, and also just wanting to see what the policy space and research space looked like. I focused a little bit on that, work with a few other professors in that area, but also I kept my eyes open in the global health world as well. But towards the end of it, I think I was having a growing interest more so in the implementation or the actual more tangible global health work more so than policy or research work. And I wanted to kind of look at opportunities that might cater to that. And towards the end of my degree, then I started looking for different opportunities. So finished in around May 2023, and then I was looking for things. And there were a few things on the table around kind of mid 2023. One of them was the program that I ended up going through, which is the Ambitious Impact, the Charity Entrepreneurship Program, which you might know is a organization and a program that helps incubate non-profits. So there are a lot of maybe for-profit incubators like Y Combinator and things like that you might be more aware of. But this is more specifically geared towards charities, non-profits. At the same time, I had kind of a few different options on the table as well. I had a WHO kind of internship kind of offer in the vaccination department that I was quite interested in. There was a residency program or like a registrar training program in Australia where I could take an academic kind of general practice pathway as well. So I've got a few options that I had to juggle. But towards the end, I really wanted to try out this kind of founding a charity idea. It was quite appealing to me personally. And I think, we can come back to it at the end, but I like the idea of starting something new, starting something novel, quite impactful, And also like the idea that, it's a job that you get to problem solve like every single day, and hopefully lead to something quite tangible and good. So that led to me founding my charity, Clear Solutions. So I co-founded it with my colleague Martin, who, we work quite well together. And I'll go into the journey that we went through since founding it a year and a bit ago to now as well. So what is the problem that we're trying to solve in Clear Solutions? It's quite a arbitrary number that you see here, which is 400,000. And that number changes every year, but more than 400,000 children, young children die every single year because of diarrhea, which is quite a, yeah, interesting figure, or like it's not even tangible to some sense. It's a number. It's when I look at it and I try to kind of maybe conceptualize this a little bit better before, and the entire population of Iceland is below this. So think about that every single year, this many children die because of diarrhea, which is a very foreign concept for a lot of us who live in high income countries, because it's not even that big of a problem. And maybe like 1 in 100,000 children die every year in high income countries. So that was a problem that I was made aware of during my kind of master's degree, but also during the program as well. And it was something that I found to be a little bit like stupid in some sense as to why this is like still a problem and why is it not being tackled. And the solution to the problem is also no, which is also a remarkable thing about it, which is oral rehydration solution and zinc. And I hope this is not too triggering in terms of going back to your biochemistry lecture, but oral rehydration solutions been known for a very long time. So it's just a mixture of water, sugar, and salt. And it's been known for around 50 years. In 1978, the Lancet article said this is one of the potentially the most important medical advancement in the century, because it was so effective at treating diarrhea. And a recent meta-analysis of like 157 studies in 2010 showed that it can prevent like 93% of diarrheal deaths. And if you think about it, it's just water and sugar and salt. So it's extremely cheap as well. It costs less than maybe 30, 50 US cents per treatment. And the mechanism of action is quite fascinating, which is that the glucose can activate this sodium SGLT1 kind of panel in your gut, which at the time of diarrhea, because the diarrhea is a disease where you can actually absorb water quite well, activating this channel can actually improve the water absorption. So it prevents dehydration through this mechanism. It's quite simple, but very effective. And also zinc has been kind of gaining more momentum and more evidence base, where it kind of functions to boost your immune system. And it's been shown to reduce the duration of the diarrhea episode and prevent future episodes for around 2 to 3 months. So now it's a common kind of regimen or treatment to give ORS and zinc for diarrhea, especially in low and middle income countries. But the problem is that in a lot of the world, especially in sub-Saharan Africa, the usage of ORS is quite low, or it's like plateaued a little bit. So past 50 years, ORS has saved millions and millions of lives, but it's getting to a stage where it's kind of plateaued and it's not advancing any further. And a lot of countries have less than 50% of the children actually accessing this kind of cheap but life-saving intervention. There are many kind of literature around why this might be the case. And maybe there are like 2 key challenges. Maybe one is access. So maybe they can't afford it. It's a bit too expensive, even if it's cheap, but these are people in absolute poverty. So this can be hard to afford. But maybe it's not even available in these countries. So the supply chain is poor, manufacturing capacity is not there, and things like that. Also, educational element play a role. So in a lot of the contexts, there might be low perception of ORS as a medicinal value, so people don't get it. The usage might be difficult because you need to mix water and all these solutions. In the Nigerian context that we work in, actually, there's an element of diversion where, the intended recipient, maybe the children, are not receiving it because the adults use it for like hydration purposes. So there are many challenges and kind of hypotheses as to why this might be the case, and the accounting for the plateau in the usage rate. And what we looked at was in 2019, there was a randomized controlled trial published in that was based in Uganda, and it tried to test this hypothesis that at current status quo, a lot of the diarrhea treatments are reactive to some sense. If the kids have diarrhea, they seem bad enough, they're taken to the hospital and then they're treated with ORS. So what if we remove kind of a lot of the barriers that we could think of? So instead of going to the facility, we go to their home and then we give the ORS for free so that they don't have to pay for it. And then they're delivered by people who are trusted, like the community health workers. And the result of that is that the caregivers of the children are educated around this, are told how to use the ORS, and they're ready to use it when the kids actually have diarrhea. So it's a preemptive element of the distribution. And the result was quite good. It was a 19 percentage point increase in the use of ORS, which when you equate the cheapness of the intervention, the effectiveness of the intervention, it can lead to quite a remarkable result. So our idea was to see if this is replicable or like translatable in different contexts. And we went to Nigeria first because we did an initial assessment based on the mortality burden, the usage rate, and things like that. And it seemed like a place that we could kind of start well in. So this is what our kind of first year or so has looked like. We were funded towards the end of September, like October, and then we ran a pilot, and then we ran kind of 2 iterations of our intervention in order to scale up the work and then to have an evidence base for it. So at the beginning, we reached around 7,000 children under 5. And then we did the very similar thing to the RCT in Uganda. So we recruited community health workers, we trained them, we gave them ORS to distribute to the household, and then they went around, educated the caregivers, and then gave out the ORS. And the result was quite good. It was actually even better than the RCT done in Uganda, where there was all doubling of the treatment effect. But it was quite small. It was a pre-post study. So, there's caveats to the result as well. So kind of encouraged by this result, we wanted to scale this up a little bit more. So around May period last year, we increased the distribution size to around 20,000 children under 5. We partnered with the government. We trained more health workers. We tried to do a little bit more of a robust evaluation with quasi-experiment. And I'll show you the result of that a bit later. And after that, which was quite successful as well, we wanted to improve the operations even more. So we kind of are towards the end of phase 3 that you see here, where we are doing continuous distribution of ORS, and then we really improved the digital tracking so that we're getting faster feedback, we're getting the operational efficiency and things like that. So we aim to do that. And to give you a bit more flavor as to what we actually do, the pilot was run in this kind of configuration. So before the pilot, Martin and I were researching a little bit more into where we should go, how we should do it, what kind of diet we should have. And it looks something like this, where we train and recruit data enumerators. And they go to the communities that we're going to distribute the ORS to. And then we do something called baseline survey. And then we have a bunch of questions that we train them on to make sure that delivering the questions properly. And they gather initial data as to what the status quo is. And the main thing that we're interested in is, how many children with diarrhea actually get ORS. And then we conduct our distribution, which at the time was around 5 days. Then at the end of distribution, in order to make sure that it was done properly, we do a community spot check. So we ask the enumerators to go back and then at a kind of low sampling rate, kind of ask random households to see if they've received the intervention in the first place. And then there's a gap between when we do these and then when we have to do a follow-up study. And the idea is that because what we care about is like the behavior with the kids' diarrhea, we need to wait until enough diarrhea cases occur. So after around 6 weeks, we do a follow-up visit whereby we ask the caregivers whether they use ORS for the child's diarrhea. The idea is that if the intervention is successful, then there will be a difference between the baseline survey and the follow-up survey, which as I alluded to earlier, had a very good result. And then here are some photos, maybe it's a bit too small. But this is what it looks like on the ground. So we're in the northern Nigeria context. We're in the Kano state. And people live in houses, and then these are our community health workers, and then they knock on the door, and then they try to distribute the product that you see on the right. And then you see 2 RS sessions, and then each RS session make up 1 liter of the solution. So they have to get a liter of water, and then mix that, and then give it to children after every diarrhea bout. And like medically speaking, I guess the idea is that we are replenishing the losses. So the kids are losing the fluid, and then with the replacement, hopefully they're maintaining good enough volume. And kids are especially vulnerable to quick fluid losses and their hemodynamic stability because their reserve volume is so low. And that's the reason why it's kind of so important and effective to be able to hydrate them. And then, there's instructions that's very picture heavy because many caregivers, especially in rural areas, aren't able to, may not be literate. We also have, like in the instruction, kind of some warning signs that they have to look out for in order to care sick, because we don't want them to just kind of stay at home, just with their ORS and things like that. And then some pictures from phase 2. So we went back a second time. You can see me in the middle there, and then we've got 20,000 ORS. So it's a lot more than what we initially did. You have to solve the supply chain problem as well as like logistically how to deliver them, like distribute them down to the community level, and things like that. And the left, you see what's called like count analysis, where before the distribution, we want to make sure that the community knows that something like this has happened, because we don't want them to think that we're like a random kind of thing that's happening that might be harmful or something like that. So if we do an activity to sensitize the community. So it includes maybe like a town meeting. It includes things like announcing the distribution at the mosque. It also includes things like a person going around with a megaphone along the street to let them know that this is happening the next few days. And the picture on the right are some of the operational challenges that we might face on the ground. So we had torrential rain during one of the periods. So like the cars got stuck. We had to cancel distribution and move it to another day. So yeah, it's not all smooth sailing as you might see in a quick report, but yeah, it is a very interesting problem that we have to solve and get hold of. And this is like an example of the result that we have. So phase 2 result is probably the most detailed one that we have. This is the one where we distributed to around 20,000 children, and they conducted like a quasi-experimental study is what we call it, which is not a randomized controlled trial, because we haven't randomized our sample, but rather we've said, look, we're going to do distribution as planned, but we want some level of comparison. So we choose it after the fact to ensure that whatever changes that we observe in our intervention group or like a distribution group, we are able to attribute it to our kind of program rather than other things that are happening. That's the idea behind quasi-experimental. So there are a lot of limitations within it as well, but it gives us more flavor than the pre-post that we did in the pilot. So you can see that the orange one is where the communities that we did the distribution, and the gray ones are no distribution. And there's a market improvement in the usage rate after we have distributed. We also see an interesting pattern where, over time, this effect is kind of lost and kind of diminishing, which is an important learning for us because this might help us understand how frequently we might need to go back, as well as, what the overall impact throughout the year might be. So we're still analyzing a lot of these, but I think overall it was a very positive result that we saw. And then phase 3 is the phase that we really focus on operational efficiency or like digitization element. So it's a quick demonstration of kind of what tools we've adopted. Before this, we tried to use paper record, which is what the government and the existing healthcare workers were used to. And we wanted to utilize the system that they were already using, because they would be easiest to adopt and kind of scale in some sense. But we saw a lot of limitations that we thought it might be worth trying, like a smartphone-based kind of tracking of the distribution. We're able to faster feedback, more accurate understanding of where things have happened. And it just allows for better attribution of our work as well. And yeah, what you see here is that each dot is like a distribution that happens, and then the different colors represent different community health workers. It's more of the distribution size that we actually use it in. And then you're able to get a level report like this, where we can see, right, X percentage of the ward was covered, and we're able to do some geospatial analysis as well. So that's a little bit about kind of our operation and where we are. And this is the team that we work with. So we've grown from just Martin and myself on the right to now having two more staff. Is our Nigerian employee, and he has lots of experience in the community element and social behavior change as well. And he helps lead the communication between us and to our partners on the ground, our community health workers, training, and things like that. So we're very lucky to have him. We also have Saha, who is a dentist by training. So it's a different type of doctor that we used to. But she's able to help with some research and programs element, and it's quite helpful there. Martin, my co-founder, I've introduced earlier, and he is an ex-Google engineer. So he has no health background at all, but he's been working at Google for 15 years, and he's able to bring a lot of kind of managerial experience as well as like technological elements. And, you can see the application just before with the geospatial element and tracking sort of those and things like that. And myself, and you've heard a lot about me. And we also work with a lot of partners. So we have our implementation partner, who is our main point of contact in terms of the manpower required to coordinate these activities, hire people as required, and then engage folks as well. So that's side of Pro. And then we work very closely with the government. We need to make sure that we get government approvals, work with their staff and things like that. So you see the Ghana State Ministry of Health, as well as Primary Healthcare Management Board in Ghana, the two entities that help coordinate at the state level. And Novelty is our kind of technical partner in some sense, who helps, who have initially developed the geospatial tracking tool that we are using now. It was initially developed for a polio program. If you're familiar, polio program is a very large program, and we're at the verge of eradication, hopefully. But they require quite an intense door-to-door visit to provide vaccination to children. So the same foundation that we want to base off. So it's quite a helpful tool for us. So yeah, and I guess the interesting thing about this kind of job that I'm in compared to clinical medicine is, it's a completely different world that we might be used to. I should cover this in the next slide. Maybe I'll talk a little bit about that. Clinical medicine is working within a very kind of confined environment, normally in a hospital, and then you have your very clearly outlined hierarchical structure from your specialists or consultants down to your kind of residents or specialist training and the interns and the medical students and whatnot. And then your roles are very clearly defined. The outcome is quite well defined. And it's hard work, but it's I think, a different type of challenge that you solve compared to what I do now. Because when we first started, it was completely uncharted territory. No one was doing what we were trying to do. And then you're designing the intervention from scratch, the training materials from scratch. You're designing how to measure what you're trying to do well, training them as well. And then you have to analyze all of those things. So it's a very different world, and we have new challenges every day. And the type of problem solving we do here is, at least for me, like a lot more attractive. I feel like I'm solving problems that are quite valuable and impactful for the world. And yeah, it's a whole different world that we live in. But I think I have some kind of reflections and thoughts as well that I have as I've kind of done a year and a bit, or maybe like 2-3 years, if you include my kind of masters as well, of kind of this career pivot I've done from clinical medicine to what I do now in the global health and charity world. And like, I think some questions that I'm hoping that you ask yourself, if you're in a position to ask, is, what do you hope to achieve with your career? And I think it's a quite a big question. And I hope none of these sound accusatory in any means, because everyone is different, and everyone have their path and their interests and their desires. But I think it's a good question to reflect upon yourself as, you see the end of your career path, kind of what do you see, like what do you want to achieve? And I'll go a little bit more into it later, but what's your risk tolerance as well? Because I think that's something that a lot of us, at least for me, struggled quite a bit in terms of what I'm willing to risk to achieve, like maybe what you want to achieve. And it's a very interesting thought for doctors, because in some sense, we're risking a lot. We have a very nice career ahead of us. Whatever we do, we know we're making an impact on people's lives. It's financially very stable. It's respected in the community. And, you do have potential to a lot of different things with it as well. Like you could do research, you could do teaching, you could do whatever else. But at the same time, having like this medical license means that you can always come back to some degree. And at least that's kind of what I think. That because you have such a stable kind of base to go off, why not risk a little bit more and see if you can achieve something better? And I think that's kind of the driving force that led me to consider the pathway that I did. And who knows, maybe I'll go back to clinical medicine in the future as well. But I think from my perspective, it was something, in some sense, a very low risk that I took in jumping into this charity world, because I can always go back to medicine as well. And something that I have that helps me with a thought experiment that I always go through when I'm thinking of my career, which I think a lot of you hopefully are at a stage either during medical school or just after graduation, or just you're very well into your career. Is that like I think a lot of our decisions are somewhat based upon the things around us, and the thought experiment that I like to do is to limit it. So I like to imagine like being in a room, and in this room there's like no one else except for you. There's no well-meaning parent reminding you of like practical considerations. Like there's no friends who's like, going well ahead of you in your clinical training and you're becoming a specialist. There's no social media, anything like that. So there's no cultural expectation, no familiar pressure. You're in a room by yourself, and you can be anyone. And now think about like where you are, where you're right now, and then where you're hoping to go, or like what your current career trajectory is. Because in some sense, in medicine, it's a side. Like, if you're like, I want to be a cardiologist, like that path is very clear. So what does that look like? And then think about whether you want to do something else. If you could do anything, if there were no limitations, you couldn't fail, you had unlimited resources, you want to make like the type of impact that you think is possible in the world. Like what would that look like? What problems do you want to solve, and what mark do you want to leave in the world? And lastly, I like to think of like picturing myself looking back at the end of my life and seeing what I've done with my life. Do you regret trying something? Do you wish that you would have been like more brave to try something else? Story do you want to tell? And yeah, how does that look right now in comparison? And I think it's not something that I want you to answer right now, because it's something that requires a very deep reflection, like a time alone. But something that helps me quite a bit in terms of figuring out what I really want to do with my life. And there are a lot of obstacles in our lives, whether it be financial, familial, like whatever else, and they might be very real. So it's not to kind of downplay any of those things or pushing anyone in a certain direction, because perhaps for some of us, like doing what we're hoping to do is like the best career path forward. But for me personally, a lot of these obstacles feel like were kind of expectations not put on by me necessarily, sometimes overcomable, and especially in expectation of what could be possible, something that I'm willing to risk. So those are kind of some of the decisions that I've gone through, where I thought, I think medicine is a great career path. And I think it'll be great to kind of go on the current trajectory that I wanted to. But while I'm still young, while I have this kind of safety net, why don't I just go try something crazy and see how it goes? And maybe the reality is that I'll fail, it might not work out, but like at least I've given it a try. And I think now is probably like a better time than any time to actually try something new. So those are some of the thoughts I go through, and maybe hopefully helpful for you. But our life is full of decisions, so it won't be the first, it won't be the last. But hopefully, what I've gone through and my experiences is at least somewhat helpful in making a decision for yourself. So that's about it for me. Thank you very much, and then maybe I'll pass it on for Q&A.
So much. That was super helpful and I think relevant. At least three people in the room. Uh, um, yeah, maybe I'll open the floor up for any comments, questions. Marie, you want to say something?
Yes, Charlie, I just quickly wanted to say I also think wrote it in the chat that I really liked your thought experiment. This is so helpful, and I'm now thinking, oh no, why haven't you told me about this earlier? I could have used it in all the time at 31. But yeah, thank you so much for letting me know now. I think it's something like this is really helpful. Probably not only for a career decision, but for other decisions maybe as well, to help our brain basically get rid of the outside influences, our outside influences. So thank you so much for that.
Yeah.
I do have some questions that came up in the Google form. So I don't know if you had access to it, Charlie. One of them, I believe you have already answered it, which is how did I pronounce your last name? Jeong?
John, yeah.
Yes. How did Dr. Jeong start out on this path, which I think you kind of covered with your very first slide. And the other one is financial circumstances leading a charity. It's not really framed as a question, but would you like to tackle it?
Yeah, no, I think it's a really good question. And I think probably applicable to not just charity context, I guess any career context where maybe finances might be not as guaranteed or like attractive, just clinical pathway. The salary really is not that attractive. And it is a bit of a, I think, shock going from like a normal full-time income to this initially. So I think I have a few thoughts here. One is we can actually live with a lot less than we think we need. So I think that's like one element that I found. My initial shock actually came through my master's degree because we go from full-time income to no income, and I was just getting paid stipend, which is quite low. And I was like, oh my gosh, and like for the first time, like how do people live like this? But you adjust quite quickly. And I think a really good perspective to have, if you can, is like there are a lot of people in the world who live with a lot less. So that's another helpful thing. The other is, I think in whichever career path you choose, the immediate financial circumstance is not necessarily like indication for like your long-term financial circumstances. So for us, we purposely gave ourselves quite low salary initially because we weren't sure exactly how the charity will pan out. And we had this vision of kind of finishing the path quickly, and then after that, we would have a better idea as to the long-term future of the charity. And once it became a little bit more certain that this would be like longer than a short-term project, we kind of can give ourselves a bit of a pay rise or like an increase in pay. And so we do so. And, while it's still not comparative to any clinical salary, it's not, it's once again livable. And I guess the longer that you spend and the bigger organization goes, depending on your perspective around how you should structure the salary or the organization will spend, it can be a factor that is not as big as one would think. So I think I'll probably say those two things. And, you might have a career pivot later in life where you have a lot higher income as well. So, I think it's an important question, something that I asked myself quite a lot before I started this and also now. And especially coming from a background where maybe like financial stability is quite highly valued upon. So, yeah, I'll say that.
Thank you for answering that. I think, yeah, super relevant, especially for a lot of us here in the room who are junior to mid healthcare professionals. I am also now going to make an appeal to everyone here in this. If you can unmute, turn on your camera, ask a few questions. Nice. Yes, go for it, Hannah. Yes, that was accident.
In case it's not working, Hannah has also written something in the chat.
Sure.
Yeah, she wrote, "Love this presentation. Your work is really inspirational. Quick question. How specifically does the interest in your team contribute to clear solutions?"
Good question. She mostly works as her title is research and programs associate. So she does a bit of everything. She's, I think, I would say a bit more of a generalist than a specialist. And she also has kind of done some research before, which helps with the research element in terms of maybe some data analysis, spatial analysis as well, if she can. And if she doesnn't know, like, we can learn as well. In terms of program stuff, we also consider expansion to different countries and things like that. And she also strength ability. So she helps kind of coordinate some of the requests for proposals, for example, or vetting the people, organizing training materials and things like that. So in a very generalist way, I think I would say. And it's also not too dissimilar to kind of maybe what I would do or what kind of any other doctor would do in this space. It's our clinical knowledge is quite valuable in some contexts. The majority of the work is not very clinical relevant. So it's more about can you problem solve? Can you apply? Yeah, it's mostly problem solving, I would say. And yeah, it's quite interesting. And if you like that type of thing, I think you probably would value these type of work.
I have a question. I think there was something that you mentioned, which I really agree with, is that for most clinical pathways, we sort of have a straightforward way, like cardiovascular or something. But this kind of field, you said you were also the only one who is pursuing something like this back in 2023. So I'm an MPH student. So for people like me, what kind of advice do you have about starting a new venture or getting into something new? Because I don't find areas where I can take advice from. I mean, inspiration I do see, but I can't find spaces to take advice or how to really proceed or start with things. So I just want to know how to kickstart these kind of things and how you did it.
Yeah, I think it's a good question. I think for me, it was the charity entrepreneurship or AIM program that helped me kickstart. So they look for people who are able to start a charity or lead a charity, problem solve, and then give you the support behind it, such as funding and the idea and things like that. So it's a one quick answer. I can elaborate on it if that's helpful. But I guess more generally, it can be difficult. So there are, I think, maybe a few different approaches you could take. One is if you're really set or interested in this pathway, you could do some research upon it yourself. So you could say, look, I'm very interested in solving a big problem. Maybe I'll kind of research by seeing what they are. Okay, and then go deeper and say, okay, this topic area seems to be quite important. Why is it still a problem? And then you go deeper and deeper, and you'll come up with some level of kind of problem statement and a solution that you could implement, and then kind of go from there. And then I guess the next question becomes funding in terms of, okay, I want to get started, but how do I actually get the momentum and then the resources required to do so? And there are people who are willing to support new charities, such as through the AIM program. But also there might be ways to network and find funding in other means as well. But if in context outside of kind of starting a completely new nonprofit, I think there are also many different pathways that, maybe MPHs could go through, depending on the skill set you develop, because MPH is a very broad degree. I also didn't know that before I did it. But you could be specializing in like data analysis, or you have like a stronger like technical skills in some sense, in which case, you might be able to apply those in like a research context, whether it's academic research or like non-profit research or like tanks and things like that. And that also in and of itself is I think, quite a valuable and uncharted territory than others. But you might have more generalist skills. And there are plenty of organizations who like need people to project manage or like project implement or coordinate relationally and things like that, to which you could find like an opportunity through there. Because I guess like one of the most impactful things is to actually just start something completely new, because you're definitely filling a space that no one else would. But yeah, there are other opportunities that you could go into that either lead to that or support those kind of work. So those are some of my quick thoughts. If there's any more like a specific area that you want me to go into, also happy.
No, that was great. Thank you so much.
Right. With the rest of you, Charlie, where are you tuning in from, by the way? I don't know if you heard me. Charlie, where are you tuning in from?
I'm joining from London at the moment.
Okay, so a human time. I thought you were in Australia as well.
Yeah. No, I was in Australia and South Korea just before this, but I got back to London long ago, so a lot more human time.
Great. Yeah, I mean, Satika here is tuning in from Australia, so you can see the dedication. Uh,
Yeah.
okay, we have another question from Hannah in the chat.
Yeah. So she was just asking, am I based in London? Hoping to be going forward. Past year or so, I've been quite hectic. I had to go to like Nigeria for in country stuff, and also some family stuff back in home in Korea and stuff. So, but yes, I'm hoping to be based in London a little bit longer term. Um,
I guess part of the job also requires you to be kind of a globetrotter. Have you picked up anything from Nigeria?
yeah. I think the that's yeah, it is and it is in terms of globetrotter comment. I think so. Like for example, Martin has wife and two lovely children, so he's a little bit more geographically bound than I am, whereas I was able to travel a bit more freely. So I think that's another element that people think about, whether these type of jobs require you to just completely abandon all ties in life and just go galloping around the world. It could be, if that's what you want. It doesn't necessarily have to be. But yeah, but I think I really value in-country time. And if any of you have interest in global health work, and do get a chance and the ability to do like experience it, I think it is great. Yeah, you do need to make sure the time is worth it and you're contributing, I think. But yeah, I think it opens your eyes a little bit. That's why I pursued it during my medical school as well. And I think Hannah said something as well. Is there anything specific attracting London? I think the two major reasons for it is one, the time zone with the African continent is a lot nicer than the Australian and Korean time zone. So I think that's one aspect, and then the travel becomes a lot easier as well. So that's one. The other is that the community of like the charities, the incubated charities through any charity entrepreneurship program, is here, and I'm using their office space, which is quite nice. So I think it's just a better environment and more conducive for like effective, in my opinion. So I like the environment.
Fingers crossed to you. Is there anybody else who wanted to ask a question? Is there anything you want to add?
Mostly just thankful for your time, Charlie, and that you are in a very busy position. So Yeah, thank you so much.
Well, thank you. Thank you for giving me the opportunity. I wish I had knew about high med back in med school. Unfortunately, I was not exposed, but I'm glad that I can contribute in some way now. And